Chapter 19, Therapeutic Agents for the Musculoskeletal System. In the beginning of the chapter, we have the common drugs for conditions of the musculoskeletal system. We have salicylates, aspirin, non-steroid anti-inflammatory drugs, NSAIDs, and a few other ones that we will go over throughout the chapter. And I do have Tylenol with codeine highlighted. That is a C3 opioid analgesic. The skeletal system chiefly provides body support and organ protection. Bones also enable movement. Tendons attach muscle to bone, which allows bones to work as levers to move and exert muscular forces. Ligaments hold bones together at joints. This allows bones to articulate at areas such as the knee and elbow. So here's just a depiction as a knee, the interior view, and the sagittal section. Long bones such as the femur and the leg also contain bone marrow. Bone marrow's crucial role comes from its production of blood cells. Bones also store important minerals such as calcium and phosphorus. When blood calcium levels are high, the bones store calcium in cells called osteoblasts. When levels are low, osteoclasts, not blasts, remove calcium from the bones. Here's just anatomy of the bone. The two types of bone are compact and spongy. Compact is also known as cortical bone. It's dense and found near the bone's surface where there is the greatest need for strength. Spongy bone, on the other hand, is typically on the inner parts of the body. And the spongy bone, which is sometimes called the cancellous bones, is where bone marrow resides. And this is three-dimensional diagram showing the microscopic structure of bone. It's kind of interesting. Here's the spongy. Here's compact. And then it kind of shows you all of the, in between all the arteries and veins. The body has three types of muscle: skeletal, smooth, and cardiac. This chapter focuses on skeletal muscle, which attaches to bones to enable movement, such as walking, talking, and chewing food. It's also important to understand how these muscles work so we can understand medications that work by affecting muscle contractions. Hundreds to thousands of muscles called muscle fibers make up skeletal muscle. These fibers are in turn grouped into bundles called fascicles. A group of fascicles makes up a muscle. So there's a figure of the muscle structure. And this is a depiction of a muscle contraction. So what signals actin and myosin filaments in the skeletal muscle to contract? While motor nerves, they are nerves that carry signals from the central nervous system to the muscle, the skeletal muscles, telling them to contract. A given motor nerve can signal anywhere from 1 to several hundred muscle fibers. The neuromuscular junction is the point where a motor neuron meets and signals the skeletal muscle. Various musculoskeletal conditions can affect the bones, skeletal bones, or both. And we will talk more on the other bones later. Osteoarthritis is a disease associated with aging that affects articular cartilage, which is the cartilage that lines the joints. It is the most common form of joint disease, osteoarthritis. Risk factors are increasing age, obesity, repetitive joint overuse, and joint trauma. And of course, genetic and environmental causes can also play a role. Here's just a severe case of osteoarthritis. Osteoarthritis differs from rheumatoid arthritis in several important aspects. Unlike RA, which is rheumatoid arthritis, there's no systemic illness associated with osteoarthritis. Acetaminophen, which is commonly abbreviated as APAP in the United States, is both an analgesic and an antipyretic. Unlike aspirin, it lacks peripheral anti-inflammatory properties or platelet inhibitory effects. Acetaminophen misuse is the most common cause of acute liver failure in the U.S. Many cases are unintentional because many products contain acetaminophen. This makes it way easier to overdose. And this chart 19.1 has select non-opioid analgesic medications. So of course we have Tylenol, acetaminophen, and again some of our NSAIDs, not probably all of them are listed here, but there's aspirin, ibuprofen, naproxen, which is also naproxen sodium, which is Aleve. There is Mobic, Relafin. So Tylenol comes in a few different routes of administration: oral, tablet, or liquid, chewable. I believe they still make that. There are rectal Tylenol suppositories, and of course, we can give it intravenous in a hospital. Aspirin, some reported that willow tree bark effectively reduced pain, fever, and inflammation in England in the early 1800s. Henry Leroux, a French chemist, found a bitter glycoside produced in the medicinal bark's properties. This chemical was called salicin. Chemists can break salicin into glucose and salicylic alcohol. Salicylic alcohol can break down into acetylsalic acid, which is aspirin. The Bayer Company first marketed this miracle agent in 1899, and they called it the wonder drug. Aspirin is an effective fever, pain, and inflammation agent. However, parents should avoid giving it to children, especially pediatric patients with flu-like symptoms, because it can cause Rey syndrome. This condition may develop after a chickenpox or upper respiratory tract viral infection. Important thing to know for any job in pharmacy is the maximum dose for aspirin in adults is 4 grams per day. Aspirin is a salicylate drug and a prototype for the newer non-steroid anti-inflammatory drugs. NSAIDs and aspirin differ slightly chemically, but they all have analgesic, antipyretic, and anti-inflammatory properties. NSAIDs also exert an antipyretic effect by acting on the hypothalamus, the body thermostat. Manufacturers created more than 12 prescription NSAIDs. A few are available over the counter, and wide variations exist between NSAIDs, even if they belong to the same chemical family. They can treat conditions in chronic illness, such as muscle pain, rheumatoid arthritis, joint pain, which is osteoarthritis, and menstrual type pain. And that's just going over the medications. Ibuprofen is available orally, liquid, chewable, tablet, and intravenous. Naproxen is only available orally. Same with meloxicam. So first generation NSAIDs inhibit both COX-1 and COX-2 enzymes. This decreases inflammation, pain, and fever. Inhibition of COX-1 enzymes have serious side effects, including gastric ulceration, bleeding, and renal damage. The theory behind COX-2 selective inhibitors is that they could treat pain and inflammation without the risk of non-selective agents that also inhibit COX-1. However, in practice, selective COX-2 inhibition has not reduced NSAID-related side effects as expected. Celebrex is the only COX-2 inhibitor approved for use in the United States. So that's important to remember. When medications tend to be the only one in the class, that tends to be something I see on the PTCB practice exams, questions related to those. Topical products can help OA and muscle strains. Patients widely use products containing menthol and methyl salicylate, like Bengay or Icy Hot, Aspirin, and Tiger Balm, and they should only use this on intact skin. Opioid analgesics play a pivotal role in pain management through actions on the brain's opioid receptors. There are three main opioid receptor types, which are mu, kappa, and delta. Activation of mu receptors produces analgesia, miosis, respiratory depression, euphoria, decreased GI motility, and physical dependence. Opioid medications are controlled substance. The DEA schedule depends on the agent and the formulation. Because opioid medications cause sedation and respiratory depression, overdose may be potentially life-threatening. Opioid antagonists such as naloxone and naltrexone can reverse the opioid effects by competing for opioid receptor sites. And here's just a mechanism of action in the spinal cord, of opioids in the spinal cord. And here are some select opioid analgesic and opioid receptor antagonists. So we have Tylenol with codeine. We have hydrocodone. Now these formulations I don't believe are available in brand name either. We just have Norco. So Lortab and Vicodin were taken off the market due to their high Tylenol content. I know they were working on reformulating them. I don't know if that happened or what's going on with that, but we also have Oxycontin, morphine, Dilaudid, Opana, Duragesic, which is fentanyl, and methadone. And we have partial opioid agonists such as Subutex and Buprenex, and mixed opioid agonists like Nubain. Then we have reversal agents, Narcan and Vivitrol. Hydrocodone is available orally. Oxycodone is available orally. Osteoporosis is a systemic skeletal disease characterized by low bone mass and microarchitectural bone tissue deterioration. These bone changes lead to fragility and possible bone fracture. Osteoporosis occurs commonly in postmenopausal women, although male osteoporosis is a growing public health concern. The body constantly breaks bone down through resorption and then rebuilds. Osteoclasts are bone cells that invade the bone surface to erode it. Osteoblast bone-forming cells then fill in the cavity with new bone, which contains collagen and minerals such as calcium and phosphorus. Osteoporosis happens when bone resorption outpaces the laying down of new bone. And for the treatment of osteoporosis, we have bisphosphonates. They're usually taking, some of them are taken daily, but weekly is usually the most. Boniva, you can take monthly. Actinol, same weekly or monthly. Reclass is an IV that's given every 1 to 2 years. There is a calcitonin, which is a spray, and also available in IM and subcutaneously. A newer one we have out is Forteo that works. It's 20 milligrams subcutaneously daily for up to 2 years. And then for absolute newest, Prolia, that's an injection that is given every 6 months. So you don't take a pill every day or every week. You just go into the doctor's office every 6 months and you receive it. And that's just going more over those meds. Gout is a form of arthritis. Uric acid buildup in the blood cells leads to uric acid crystals in the joint, which in turn leads to inflammation and pain. Alcohol, diuretics, levodopa, and other drugs hinder the renal excretion of uric acid and have been linked to gout. If a patient presents with new onset or worsened gout, a pharmacist should review the medication profile for contributory medications. So for gout, we use NSAIDs. We have the anti-gout agent colchicine. We use corticosteroids, and we have xanthine oxidase inhibitors like Xyloprim and Uloric. And we have a uricosuric agent, Benural. Skeletal muscular pain can arise from many causes, although everyone experiences some pain at one time or another. Severe injury or chronic pain may need extra care. Treatments can include drug therapies like analgesics and muscle relaxers, and physical therapy for severe injuries. Surgery may be an alternative if medications and physical therapy prove ineffective. So for skeletal muscle relaxants, we have Flexeril, pretty common, Robaxin, Soma, which is a controlled substance. So when I first started in pharmacy, it was not. It became a few years after me working in pharmacy. Then we have Scalaxin and Lyrosol. Surgeons will use neuromuscular blocking agents with anesthetics for surgery. These relax skeletal muscles to induce paralysis. They help place the patient on a ventilator and to suppress the patient's spontaneous breathing after a ventilator is put in place. We divide the agents into two major categories: depolarizing and non-depolarizing neuromuscular blockers. Depolarizing agents such as succinylcholine mimic the effects of the neurotransmitter acetylcholine. Non-depolarizing agents also compete with acetylcholine but lack agonist activity at receptors. Instead, non-depolarizing agents block receptor activation by acetylcholine and prevent impulse transmission, leading to muscle relaxation. And here are the select neuromuscular blocking agents: succinylcholine, and then that's the depolarizing, and then we have all these non-depolarizing, and you can see these are all IV injections. So this should never be something that someone's getting in a retail pharmacy by any means.